Cancer is a complex disease, with lots of different molecular features that make each case unique. Most cases, over 2/3, fall into what we call luminal A and B subtypes, which means they're hormone receptor positive. For these tumors, hormone-based treatments are usually the first line of defense. One common approach is to use medications that block estrogen from activating its receptor, helping to slow down tumor growth. But even when treatment works at first, resistance can develop over time, especially in advanced or long-term cases. This resistance often happens because of genetic changes in the tumor that either reactivate estrogen signaling or turn on other survival pathways. Two key mutations we look for are in the PIK3CA and ESR1 genes. The PIK3CA gene makes a protein that helps control cell growth. When it mutates, it can activate a pathway that helps cancer cells survive and multiply. Some of the most common mutations in this gene have names like E542K, E545K, and H1047R. In fact, up to 40% of hormone receptor-positive breast cancers have a PIK3CA mutation. These changes can drive tumor growth, change metabolism, encourage new blood vessels, and help the cancer invade nearby tissue. Clinically, these mutations are linked to a lower response to hormone-blocking treatments. Tumors with PIK3CA mutations are more likely to spread to the bones and liver. They can also help cancer cells survive treatment and stick around even when therapy is ongoing. The good news is, these mutations can be targeted with specific therapies that block the PI3K pathway. For patients whose cancers have these mutations and have progressed after hormone therapy, PI3K pathway inhibitors are now an option in advanced settings. In short, PIK3CA mutations help cancer cells find new ways to survive and make hormone therapy less effective. That's why it's important to test for these mutations if resistance to treatment is suspected. Now let's talk about ESR1 mutations. The ESR1 gene makes a protein called the estrogen receptor, which acts as a switch to turn on certain genes when estrogen is present. Some mutations in this gene keep the receptor switched on even when there's no estrogen around. The most common of these are called Y537S, Y537N, and D538G. These changes let the cancer keep growing, even when hormone-blocking drugs are used. Studies show that tumors with ESR1 mutations tend to progress faster and respond less to hormone therapy. Treatment options here include drugs that break down the estrogen receptor, both as injections and newer oral forms. Recent research suggests that these oral therapies can be especially helpful for people with ESR1 mutations. When both PIK3CA and ESR1 mutations are present, resistance to treatment can be even stronger. In these cases, we often need to use a combination of therapies to block multiple pathways at once. For example, combining a PI3K pathway blocker with a drug that degrades the estrogen receptor can help tackle both drivers of resistance. Clinical studies support this approach for certain patients. Tumors with both mutations are more likely to spread to bones and other organs. They can also hide in the body and avoid standard treatments for a while. That's why finding these mutations is so important for both treatment and prognosis. Next, we'll look at how to monitor for these changes and what this means for everyday clinical practice. Sometimes PIK3CA and ESR1 mutations show up during treatment, even if they weren't there at the start. In fact, these molecular changes often happen before anything shows up on scans. To keep track, we use advanced sequencing tests. These can be done on tissue or blood samples. There's also digital PCR, which helps us spot even tiny amounts of mutation. Broad genetic panels let us look for a wide range of changes all at once. By checking over time, we can catch new mutations as soon as they appear. It's best to test when someone is first diagnosed and again if the cancer progresses or there's a new concern. The results help us choose the right treatment combinations or consider clinical trials. For example, if a PIK3CA mutation appears after hormone therapy, we might add a targeted inhibitor along with ongoing endocrine treatment. If there's a change in the estrogen receptor, we often switch to a different type of hormone blocker. And if both mutations are present, we look at combining different targeted approaches or enrolling in a study. Research supports these strategies, but it's important to tailor decisions to each patient. Always consider the details, how sensitive the test is, how much of the mutation is present, and how mixed the tumor might be. Ongoing blood-based monitoring can help us catch changes early and adjust treatment quickly. We use different tests like sequencing and digital PCR, depending on what's needed for each case. When both mutations are found, combining targeted treatments can make a real difference. And don't forget, Clinical trials are a great option for many patients. PIK3CA and ESR1 are key players in resistance to hormone therapy, so finding them really changes how we manage care. These mutations mean hormone therapy alone may not be enough, and targeted combinations are often needed. That's why regular genetic testing and follow-up should be part of standard care for ER-positive breast cancer. With precision medicine, we can adapt treatment sooner and help patients do better. So, the main points: test for these mutations, keep monitoring, and tailor therapy to each person's needs. For more details and protocols, check the video description below. Thanks for watching. Let's keep the conversation going in clinic and at your next team meeting.